Um, so yeah, 15 minutes all of hepatology. You know, hot topics in hepatology, I can really go on and on and on and on about it, but I'm gonna try to contain my enthusiasm for the next 15 minutes and sort of highlight what I think are, in my mind, some of the hot topics as much as I can go over in the next 15 minutes. So I've had 5 cups of coffee already. So this is gonna be a really whirlwind, quick review, so buckle up. So in the next 15 minutes or so, the three areas that I sort of chose to focus on in terms of reviewing hot topics within the past 6-12 months or so, I'm going to talk a little bit about viral hepatitis, touch on some updates we have with alcoholic liver disease or alcohol-associated liver disease, and then every talk, I think we're still in sort of that era where we have to sort of say something about COVID, and unfortunately, as we know in the Bay Area, we're still seeing a bit of a surge in hospitalizations and such. So I'm going to touch on 2 studies, one presented at, one coming up at EASL, and then one recently published in Gastro. So first, viral hepatitis. I think for me, viral hepatitis, I think it's really important to understand some of the recent updates in the epidemiology, prevalence, and sort of understand how close we are in achieving the WHO recommendations or goals of viral hepatitis elimination for 2030. This can you see in the bottom? Yeah. So this is a website that has a modeling based study called the Polaris Observatory. And it's really cool. I think I would recommend anyone to sort of look, and it's constantly updated with new data, new modeling data across the world. And in 2016, the estimate was about 292 million adults globally with chronic hepatitis B. More recent updates suggest that this is probably now closer to 270 million, probably because of less new infections due to effective vaccination, but unfortunately, also the aging hepatitis B population and people dying from Hep-related morbidity, mortality, but also HCC. But the key here I wanted to highlight here is if you look at this this panel on the website, it shows you the progress we've made with how many people are diagnosed, how many people are treated, linkage of care, all of these things. And that's pretty dismal because what the WHO recommends or tries to achieve is in 2030 that we'll have 90% diagnosed, 80% treated, and then 65% reduction in mortality. So very, very far off from reaching those goals. What about in the US? So this is data published less than a year ago that estimates in the US about 2.4 million adults with chronic hepatitis B. As we know that majority are from Asia Pacific regions, but look at the diversity of the hepatitis B population and think about the diversity of our practices, especially in Northern California and the Bay Area. So really thinking about effective screening for hepatitis B in your practices. How are we doing? If you look at the panel, better than the world, but actually not as good as we had hoped. Still only about 35% diagnosed. Of those that are eligible, less than a third are effectively treated with antiviral therapy. And really, regardless of what region, country you are, we really are nowhere on track to achieving those goals. And really, we all need to do a better job at trying to improve and get on track to achieving viral hepatitis elimination. What are the gaps and what is preventing us from getting there? Well, there's clearly gaps in the Hep B cascade of care. Screening, linkage, treatment, assessing them, and not even, it doesn't even end there, thinking about Hep B related HCC downstream. So all of these things are very important. And I think any attempt at trying to address gaps and disparities in hepatitis B really needs to take a comprehensive approach in addressing all of these issues. In particular, we know that the vast majority of our Hep B populations are underserved populations, safety net populations, ethnic minorities. So even more important to try and address the existing gaps and disparities in Hep B care. So how are we gonna get there? I think there's 3 main tenets. Of course, it's very complicated and not to simplify it, but really it's effective screening, expanding vaccination, and then reducing barriers to treatment. So I don't have time to go over all of these, but I just want to share 2 updates about screening and vaccination. We need to expand and improve Hep B screening from risk-based to universal. We've seen the failures, may I say, of Hep C risk-based screening, and now we have universal screening. We're not quite there yet with hepatitis B, but I would estimate that we're almost there with advocacy and recommending universal screening. This is a study published from the Asian Liver Center at Stanford within the past year ago to model the cost effectiveness of a one-time universal screening for all adults with hepatitis B. And you can see here, not only is it cost effective, in their summary data, it shows significant reductions in downstream liver-related morbidity and mortality. What about vaccination? These are new updates that came out from the ACIP, just published our recommendations about 2 months ago in April. We know about birth dose vaccination, et cetera, in pediatrics, but now all adults age 18 up to 60 are recommended for universal Hep B vaccination. Above 60, they're still, sort of recommending with risk factors or high-risk individuals, just because it's not quite clear about the cost effectiveness there, but definitely those age 18 to 60 are now recommended for universal vaccination. What about Delta? I'm just going to touch a touch about Delta because that's sort of a hot topic now in the field of hepatology. It's important because Delta co-infection or superinfection in Hep B patients are associated with significantly more advanced disease in terms of cirrhosis, decompensation, HCC mortality, and really there's suboptimal awareness. And that's why think about the last person you screened. I think probably less than 5% of us here have screened a Delta patient. I think these are data that was presented at DDW that looked at 2 large cohorts. One is the Quest National Laboratory Database, looked at all Hep B patients. I'm just going to focus your eyes on the first bar here. What proportion of our chronic Hep B patients were screened for Delta? What was that? Less than 7%. When we looked at the VA national cohort, about 13,000 chronic Hep B patients, also pretty low, only about less than 20% were screened. So just like the early days of hepatitis B and what we're dealing with now, I think also with hepatitis Delta, there needs to be more awareness about who to screen, how to screen. And then unfortunately now we don't have therapies, but just on the horizon, we will likely have some very effective therapies for Delta. What is the prevalence in the US? This is a global paper published by the Stockdale Group, estimates globally about 12 million. In the US, probably about 5 to 6% prevalence. And estimates are it's about somewhere between 80 to 150,000, but still some sort of lack of clarity about true prevalence, mainly because of under-testing and suboptimal awareness. Again, at DDW, those 2 data sets report a much, much lower prevalence, which is sort of confusing. And clearly there needs to be more data on sort of understanding who are the high-risk individuals that we should screen, how do we implement effective screening, how do we screen, and then eventually how do we link these people into care and treatment. Don't have time to talk about treatment, but these are some of the hot treatments that are just on the horizon for hepatitis Delta. Two ones to particularly pay attention to are the first 2 who are in phase 3 and likely will be available hopefully in the next 1 to 2 years. So that's viral hepatitis. Just going to quickly talk about alcoholic liver disease. Unfortunately, we've seen this. This is a paper published about a year ago looking at changes in alcoholic hepatitis related. First graph here is alcoholic hepatitis transplant listings, transplants, and then the associated change in increased alcohol use since the pandemic. And right after the onset of the pandemic, you see the very clear correlation between increased alcohol use and the increased decompensated disease requiring liver transplants. Other data that was recently published, this is a modeling data to estimate what is the impacts of all this increased alcohol that we're seeing post-pandemic. And they modeled and showed that a 1-year increase in alcohol consumption during the pandemic resulted in significant morbidity and mortality. 8,000 more alcohol-related deaths, about 19,000 additional cases of decompensated cirrhosis, 1,000 more cases of HCC, and almost 9 million disability-adjusted life year between 2020 and 2040. But here's the thing, it's not the pandemic is not, kind of over, but we're still seeing the increased alcohol use and a sustained alcohol use beyond 1 year. Remember, this is just 1 year modeling data. And for all of us here that see patients either in the clinic or in the inpatient setting, we are still seeing a lot of alcohol-related morbidity and mortality in both settings. And so the ultimate impact of this might be even greater. Alcoholic liver disease treatments, we don't have a lot. Alcohol abstinence, we have issues with resources to plug patients into addiction services, counseling, behavioral therapy. There's lack of novel effective therapies, especially for severe ALCAP. But we know the story about pentoxifylline really is not really recommended. And then even for prednisolone, we use it sometimes, but for those that you remember, the STOP AH trial even raised some concern about whether this is effective in reducing morbidity associated with severe alcoholic hepatitis. So there's some exciting things to share. I mean, there's lack of effective therapies now, but there's some exciting therapies that are in development. This is a small molecule, don't have time to go over a lot of the details, but a small molecule that is currently undergoing phase 2b study enrolling to look at the impact of improving outcomes in patients with severe alcoholic hepatitis. These are some of their data from their phase 2a study. You can see here, even within the first 7 days, you see significant improvement in some of the parameters that we pay attention to in assessing the severity of liver disease in those with severe alcoholic hepatitis. And then you can see here that overall the outcomes, small study, only about 19 patients for phase 2a, but still sort of proof of concept showed that there was significant improvements. And in fact, at 28 days, there was 100% survival for these patients, where traditionally 28-day survival for these patients sort of ranges anywhere from 30 to 50%. So very interesting and exciting. This is currently undergoing a phase 2b study. They have started enrolling, I think, last November. It's a 1-to-1-to-1, 3-arm placebo and 2 doses evaluating this agent for severe alcoholic hepatitis. These are the 3 centers. If you do have patients and are interested in getting more information, these are the 3 centers in our area and the PIs for these studies that are enrolling for this study. Finally, COVID-19 and chronic liver disease. So this is a study that we're actually presenting in a few weeks in London for those of you who will be going to EASL. So this is a large COVID-19 research database that's actually publicly available. So those that are interested in doing COVID-19 related, not just liver, but any COVID-19 related research. When we looked at these data were from onset of the pandemic, so April 1st, 2020 to about August 31st of last year. We wanted to understand the outcomes of patients with COVID-19 and concurrent chronic liver disease. We had a total of about 1.2 million unique patients with COVID-19 in the database that were identified during this period. About 3.6% had concurrent chronic liver disease. Of those, about 15% had underlying cirrhosis. So a good diversity of liver disease severity for us to sort of really understand the outcomes. And really the take-home points here, as you can see, in the graph here, these are the univariate unadjusted outcomes in comparing patients with the first bar is COVID-19 without chronic liver disease, and then the second bar are COVID-19 patients with chronic liver disease, and the outcomes that we focused on: total hospitalization, pneumonia, severe pneumonia, respiratory failure, and then multi-organ failure. And as you can see here, in the adjusted multivariate model, as expected, patients with underlying chronic liver disease had significantly worse COVID-19 outcomes compared to those that did not. Why is that important? Well, it's important really to raise awareness about implementing effective vaccination, booster, et cetera, in our liver disease patients, but also very close monitoring of these patients when they do get COVID. We know that vaccinations are helpful, but I'm sure every one of us here knows a friend or a family that has still gotten COVID infected despite vaccination. So really need to be very cautious and careful in watching our liver disease patients, especially those with cirrhosis who develop SARS-CoV-2 infection. And then finally, this paper was published just a little bit less than a year ago. Similar kind of study, but looked at it a flip-flop, different kind of way. This was the UCSF team that has a multi-centered collaborative looking at, again, understanding the impact of chronic liver disease in COVID-19. There's the study design was a little bit different. They looked at 220,000 patients with liver disease. Not everyone was tested. So of those, about 60% had COVID testing. And so, of those, total, all of those had COVID testing. And then they stratified by liver disease severity and whether you were positive or negative for COVID. And so that's what these different pairs mean. So the first group were those that were non-cirrhotic, negative, meaning no COVID infection. The second group were non-cirrhotic and positive. The third group were cirrhosis and no COVID. And then the final sort of presumably sickest group were cirrhotic patients that also had concurrent COVID-19 infection. Overall, 30-day mortality was 4%, 3.9% in cirrhosis patients without COVID infection. And as expected, if you had a cirrhosis and COVID, your overall mortality was more than double, almost 9%. When they looked at, this is a very nice Kaplan-Meier curve looking at the stratification between the four groups. As expected, the best survival was seen in those with, as you can see here, non-cirrhotic and negative COVID infection. And as you can see here, the different groups, with the sickest group with the worst outcome, of course, those that are cirrhosis and COVID. So really showing the additive effect of having underlying liver disease, particularly cirrhosis, and having COVID-19 infection. So with that, I would just quickly summarize some of the things that I said. Hep B and Delta remain major global burden and contributor to liver disease, morbidity, and mortality. I think we really need to focus on improving screening for these patients and effective linkage to care, because once you screen and link them to care, only then can you really talk about implementing effective antiviral therapy. Vaccination, also important, especially with the new guidelines now recommend, or ACIP recommendations for universal vaccination in adults less than age of 60. And then Delta is a hot topic to be aware of because it is associated with very severe disease progression, morbidity, and mortality. Alcohol, as we know, is rising burden, especially during the pandemic, and continues to have a big, important burden in contributing to liver disease-related morbidity and mortality. Lack of effective therapies, but some interesting data on the horizon that we should definitely pay attention to. And then, you know, COVID is slowly going away, but I think it's something that we need to still be cognizant of because it does affect outcomes in our GI patients and especially our liver disease patients. And then one thing I didn't have time to talk about, but really we still don't know what are the implications of long COVID. People that have had it, recovered, or had it multiple times. What is the implication of that on long-term liver disease outcomes or outcomes in general, which we don't really know about? And then final plug, if you find any of that exciting, stay tuned. We do have our Winter Liver Symposium in January, where we have an entire day devoted to hot topics and exciting things in hepatology. Thank you. And oh yeah, Dr. Chen. Yeah, that's a lovely question. So the question is, for universal vaccine, should we just vaccinate or should we be screening first? So we should be screening first to make sure that they are not already infected or have a core antibody positive before you vaccinate. Unfortunately, because the way the CDC and the ACIP works, they haven't made that recommendation yet. But we're trying with advocacy groups, et cetera, we're trying to push for that language to say, yes, you should screen before you vaccinate, because if you vaccinate someone that already has chronic Hep B or has core antibody positive, not only are you providing false reassurance, but you may even be masking the potential for undiagnosed chronic hepatitis B. So in what I would recommend clinically is screening before you vaccinate to really, do it the correct way. Thank you. Yeah.
In the slide regarding the poor outcomes for COVID in liver disease, did that include NASH and NAFLD or just cirrhosis?
Yeah, for the latter study that was published, they didn't stratify by etiology, but they did include patients with NASH, alcohol, some viral hepatitis, but vast majority were NASH and alcoholic cirrhosis. In our study that's going to be presented in a couple of weeks at EASL, we did stratify by etiology, but interestingly, no, the sample size is huge. We didn't see a difference between underlying liver disease, which we were a little bit surprised. We would have thought that those with alcoholic liver disease and then had COVID would have fared worse in terms of the outcomes. So we actually didn't. The caveat, though, is in that study, we were only looking at COVID-related outcomes, so pneumonia, respiratory issues. We're currently looking at liver-related outcomes. So we could potentially see a difference in liver-related outcomes when looking at differences in etiology. But it's interesting you ask, because we would have thought that alcohol, but also NASH, because NASH is associated with some of these metabolic diabetes, obesity, where some of the earlier studies in COVID actually saw a correlation between some of these metabolic comorbidities and poor outcomes, but we didn't see it in this study.
Thank you.
Yeah. Great, thank you.